Okay, so I'm going to divide my talk into these four sections. The first is about the classification of SMA clinical symptoms. Then talk about the diagnostics and genetic counseling of SMA. And I will then move into describing some of the current clinical care issues in SMA. And then describe the effort of the International Standard of Care Committee leading to the publication of the consensus statement. So, Dr. Cassell mentioned a little bit about the classification of the clinical types. And so, actually, initially there were 3 types, but recently we added the 4th type that more pertaining to the adult. So, it's the type 1 is the most severe one. The onset of the disease usually started between birth and 6 months. This is the most severe one. These children usually never sit. They could not achieve this sitting as the highest function. They usually succumb to the disease before 2 years of age. Now, the type 2 is also called intermediate. The onset usually started between 7 and 18 months. This is the time when the children are supposed to stand. They usually stand at about 12 months of age. So usually at that time, they alert the parents and the care providers. So they never achieve independent standing or walking. They usually live longer than 2 years of age, often up to adult life currently. The type 3 is the mildest type. The onset is usually after they are able to walk, and that's usually after 18 months of age. They usually can stand and walk, and then they live usually up to adult life. The type 4 is sometimes also called an adult onset. And the onset of the disease is usually in the 2nd or 3rd decade. And they usually walk, even when they're adults. Yeah. So these are the classification. Now, the incidence, this is a little bit old. Actually, the incidence in the acute, what we call the type 1, is about 1 in 20,000. The chronic ones, also type 2 and 3 combined, is about 1 in 24,000. So combined of all type 1, 2, and 3, the onset is about 1 in 10,000. But there are current studies showing that actually it's more frequent than that. It's about 1 in 6,000. So according to this calculation, if you calculate 1 in 10,000, the carrier frequency is about 1 in 50. But if you calculate according to 1 in 6,000, then it's about 1 in 40 in the carrier frequency. So the clinical presentation for the type 1, also called the Wernicke-Hoffmann disease, usually the onset sometimes could be in utero, and these are the severe type 1 when they were born with symptom already. But the regular, more of the other ones is usually born normally, but then they fail to develop some of the more milestones within the first few months. They present with severe hypotonia, and in the neurological exam, they don't usually give you an intended reflex. And they also have this quivering of the tongue, called the tongue circulation. The weakness is more in the legs than the arms, and consequently, they usually lie in bed with what they call the frog leg position, because the legs usually don't move, yet they could still move their arms. And they have this, what they call the paradoxical breathing, in that when they suck into the air, usually you expand the chest wall, but because the chest wall is so weak, when they suck into the air, the stomach actually protrudes and the chest actually suck in, and that's what we call the paradoxical breathing. They usually succumb from the respiratory insufficiency within the first 2 years of life. The type 3, the type 2 SMA, the intermediate type, the onset is usually within the first year of life, and they can sit independently. Some have done feeding difficulty and poor weight gain, and within the first couple of years of life. They also have the respiratory issues and include difficulty in clearing the airways, particularly in the, when they have in the current upper airway infection. Scoliosis is very common in this group of kids, and this often has a shortened lifespan. The type 3, also called Kluger-Verwillinger disease, the age of onset is early childhood to the late adults. So it's a very wide spectrum in this type. They usually achieve independent walking at some point of life, and lose it also at some point of life. Their variability of progression is quite wide, with some losing walking in childhood and others walk until in adult life. Again, scoliosis and excessive weight gain later on in their life because they lose their ability to walk and become wheelchair bound, and then have some excessive weight gain that will be addressed by Dr. Brenda Warren later. This is the pathological finding in the SMA. Dr. Michelle mentioned a little bit about the spinal cord. When you do look at the pathology of the spinal cord in the cross-section, in the normal subject, you will see that there are large motor neurons in this anterior horn of the spinal cord. And in the SMA specimen, you see that there is lack of these motor neurons. It's pretty smooth. And consequently, sometimes SMA is also called anterior horn cell disease. In their muscle specimen, the leg is very regular hexagonal muscle fibers. And instead, they have very large round islands of muscle fibers in the midst of these atrophic, very small muscles. And that's why we call muscular atrophy. So it's a spinal muscular atrophy. That's where the name came from. The diagnostic of SMA, this is the paper that came from, this is a paper came from the consensus statement. After prolonged discussion, we came up with this diagnostic algorithm for the clinicians to follow. If you encounter a child in the clinic with typical or even untypical features that you suspect that this child may have SMA with some of the features, then the first step is to do the SMN gene screening. If the SMN gene came back positive, then you have the diagnosis of 5q SMA. And then if the SMN gene came back normal without the homozygous deletion, then you start with the other diagnostic workup, including EMG, nerve conduction, and CT PET. If these are normal, and then the typical clinical features of proximal, then distal weakness persists, then we continue to think about this may still be an SMA, and you screen for the SMN1 gene copy. Nowadays, some of the diagnostic data will automatically give you that, but if not, then you just have to check the SMN1 copy. If there is only one copy, then this most likely the other copy has some form of the existing copy probably has some form of mutation, but it was not detected by the deletion study that's currently used in most of the diagnostic labs. If that's the case, then you're missing one copy, and the good copy that is there, not the good copy, the copy that is existing there probably has some form of mutation, and then you have to sequence it. If you sequence this copy, you find a mutation, a point mutation, then you have a diagnosis of 5q SMA. So this is kind of the algorithm to diagnose the SMA. If not, then it's probably different. Either they're not a 5q SMA or they're not SMA at all. Maybe a different neuromuscular diseases that are presented looks like SMA.